Hello, everyone. My name is Dr. Stephen Hughes. I'm a spine surgeon with Ortho, Virginia, and we're going to talk about a 100-year-old workhorse, the cervical hemilaminotomy. Dr. Ellsberg was the first to do this in the modern era of anesthetics, and indeed, until the mid-1950s, this approach was the preferred approach. Ironically, there was a generalized fear of anterior structures such as the esophagus, jugular vein, and vagus nerve that prevented it from being the real gold standard that it became after the 1950s. Nevertheless, in the 1970s, CT scanning and intraoperative microscopes refined the posterior procedure. The 1980s also saw MRI scanning and neurophysiological monitoring become more important, and also advanced the techniques of the posterior procedure. And finally, in the 1990s, revolutionary changes in instrumentation and more minimally invasive procedures really let this procedure become maximally improved. Make no mistake, the anterior approach is our workhorse. After 1955, virtually all of the procedures that we do are best treated through the anterior approach, for a variety of excellent reasons. There's less instability, less blood loss and surgical time, fewer neurologic complications, excellent research on fusion techniques, and some of the most robust and efficient instrumentation techniques that we have available are available anteriorly. So, when would we use the posterior approach, and when does that become indeed an optimal choice? Interestingly, as our modern technology has advanced, this old procedure still has an excellent criteria for soft lateral disc herniations in the context of normal facet morphology when there is normal spinal flexibility, which is our young patients for the most part. The case that I'd like to present today really illustrates that. A 23-year-old left-hand dominant woman with 6 weeks of unremitting numbness, weakness, tingling, and a loss of dexterity. She had significant neck and left shoulder blade pain, was really limiting her activities of daily life. Her physical exam was remarkable for significant weakness in the dominant extremity, and indeed she had failed 3 weeks of physical therapy, high potency narcotics, and 2 cervical epidural injections. She was progressively losing her ability to use the arm and was getting progressively weaker. Her plain radiographs indicated some local kyphosis at the 5, 6, and 6, 7 level, but no real instability to speak of. Her sagittal MRI indicates some dehydration and kyphosis at the 5, 6 and a disc herniation at the 6, 7 level. The axial images indicate that this is a soft, well-hydrated fragment that is extruded laterally. And the axial T2 images also showed that she did have significant dehydration and kyphosis at the 5, 6 level as well. She got a variety of opinions from excellent surgeons, community-based neurosurgeon, 2 fellowship-trained orthopedic surgeons, and she came with a variety of very good recommendations. A 1-level ACDF, we all know, is going to work well. 2-level ACDF also relative to her 5, 6 level, and 1 recommendation for a total disc replacement. All excellent, well thought out plans, but her mother wanted 1 more thought, and that's when I got to see her. The hemilaminotomy made a lot of sense for this lady for a couple of reasons. She was very young, the disc was well hydrated and located very laterally. I told her that I thought all these procedures would work well for her, but that she should really consider this fairly simple old procedure. We know what the disadvantages of the ACDF are in this person. It is an ablative procedure. There's a long future for troubling sequelae in her, and there really is no bailout procedure for her with this surgical intervention. Look at the x-rays on the left. You can see cervical disc replacement, while it's an excellent procedure, has got its own disadvantages. There is still autofusion. There is still adjacent segment degeneration. And importantly, I think in her, and not talked about too much, is the fact that the majority of the implants do have a significant amount of cobalt chromium, and as such, they inhibit MRI scanning down the road. The hemilaminotomy, on the other hand, is not ablative. We have a long history of using it. There's a very narrow patient selection, which makes it fairly easy to pick out. There's very simple rehab for a majority of these patients, and they can expect, for the most part, full recovery. It is indeed a surgery with a, quote, cure, unquote. There's no effect on future MRIs, and there are multiple bailout procedures should the procedure not work. We are, of course, talking about unilateral left C6-7 keyhole microhemilaminotomy. Gardner-Wells tongues are used to position the head. Fluoroscopes, lateral fluoroscope positions her. Triggered EMGs for the C5 root and SSEP monitoring, while optional, are a good choice. It allows for a 1-inch incision. The root can be visibly retracted superiorly, very simply, and the large extruded fragment typically pops into the field, even without any spinal cord manipulation. Remember to preserve at least half of the facet to minimize instability. Make sure that you use bipolar and slurry application to minimize bleeding. And after 6 weeks of rehab, back to normal activities. And indeed, at last follow-up 6 months post-operatively, this woman was happy and had recovered all of her strength. Again, thank you all for listening, and I hope you remember this excellent old procedure.